Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Megan Mahoney. She's a family physician and she's on the board of governors at the Doctors Company, long-term KevinMD supporter. And we're going to talk about her KevinMD article, Primary Care 2.0, New Thinking and Practice Redesign. Megan, welcome to the show.
Thank you. Thank you for having me.
So we'll get into your article in a little bit, but first off, briefly share your story and journey to where you are today.
Sure. Thank you. I've been in primary care, a family physician for 20 years, mostly in the Bay Area, but I spent several years in Nairobi, Kenya. I was primed for a career in academic and community medicine because of my parents. My father was a civil rights and community activist, and my mother served as the president of a historically Black university. I have led primary care and population health innovations in many settings, in HIV clinics and prisons and in rural Kenya. And now I serve as the chair of the Department of Family and Community Medicine at the University of California, San Francisco. And I've taken this position at a time of crucial transformation in primary care. And I see this as an opportunity to harness the many learnings that can come from an academic department to give a critical voice in this unfolding primary care transformation. Primary care is one of the largest aspects of the healthcare system. And we have nearly 500 million visits to primary care physicians each year. And over half of all of physician visits are with primary care physicians. Investing in a robust primary care physician pipeline across the country will have a positive impact on quality of care, lower costs, better patient outcomes, and also better outcomes for the workforce. And this time, I think it will be different.
All right. And as you know, and as my listeners know, I'm a primary care physician myself, certainly interested in hearing about all the reforms and changes in primary care we could make. But before we get into that, we have a lot of medical students who also listen to the show. And I also like to ask primary care physicians on the show, why do you love primary care? Why primary care? Why should medical students consider primary care?
Thanks for asking that. I went into primary care because I wanted to be my family's physician. I wanted to be my community's physician. I had this idea of walking in the neighborhood and seeing somebody who I could help in clinic. And I've been in academic medicine, and that definitely has played out where I've been able to take care of colleagues in a longitudinal basis. I've been able to help them in the time of need. So even when they're facing a very medically complex issue, I'm there to walk along that journey with them. I also love taking care of multiple generations in a family. And in one case, I have a family, 4 generations in that family that I take care of. So we provide care from cradle to grave. We're there at the beginning and at the critical end of life and all the issues that come up. And I just like to be that companion, that captain, that champion for my patients. That's what I love about primary care.
So as you know, there are a lot of challenges that prevents primary care physicians from achieving that vision. And before talking about your article, tell me about some of the obstacles that primary care physicians face today.
Sure. So I think recently we saw in general media a study that came out about physician burnout. And we have a very high rate of physician burnout, unfortunately, up to 63% in the most recent survey. Physicians attested to at least one sign of burnout. And among family physicians and primary care physicians, the rate was of the highest. And so we are confronting a widespread burnout issue. I think it's because we haven't really been able to develop those care models yet that will support primary care physicians to do their best work and work in teams where all of the team members are practicing at the top of their license. On top of it, there's a deluge of data that's coming. We love these patient messages, especially during the pandemic when we were really serving as a lifeline during a time when people were confused. They had a lot of questions. There was a lot of different sources of information, and many people went to their trusted family physician or primary care physician and that time of critical need. But in primary care, we're seeing just so many messages come in, so many different streams of data come in that we're managing. And that is the time when we need to make technology work for us as opposed to being, a victim of all of that data. And so building the right team to address the new way in which primary care is practiced so that we can offer those video visits. I love seeing my patients in their home and their family, and I love being able to review their medications right in front of the camera with them. There's so many advantages in the way that we're practicing primary care at this time. It's just that the organizations need to catch up to really support primary care. And then there's a macro issue around economics. Primary care physicians are not being paid as much as other specialties at this time, and that is improving slowly through CMS, but it's not addressing this workforce shortage that we currently have. We currently have around 15,000 physicians that we are needing to serve underserved areas throughout the country. And over the next 10 to 15 years, we're facing a shortage of 48,000 physicians. And that's going to be really hard as we start thinking about how chronic disease is becoming more prevalent, how we think about the different ways in which we want to help our aging population, and then also the ways in which we want to effectively address social determinants of health. And so this is very critical at this point. And I do think that those serve as barriers, but they're all surmountable. They're all things that we can address.
So let's talk about some of your solutions, which you discuss in your KevinMD article titled Primary Care 2.0, New Thinking and Practice Redesign. Now, talk about how does the article come together?
Sure. Well, as a primary care physician, the article was inspired by one of my patients who I refer to in the article as Ruby. Ruby is a 79-year-old woman who comes from the same area that my mom is from in Tennessee. And I describe her care experience in an innovative primary care model that I hope illuminates several principles that have informed this new thinking in primary care and practice redesign. And when I was serving as the president of the medical staff at Stanford Healthcare, I was invited to give a talk about transformation in primary care. And in preparing for that talk, I conducted an assessment of what primary care looks like now, and I looked at analyses that helped me understand what it was going to look like, what it's going to look like in the future. And I also am thinking about how we need to design, we were talking about medical students, how we need to design medical education and residency training to help prepare this future generation of primary care physicians, because we're really at the vanguard of healthcare transformation. And in many ways, primary care is front and center. And so that's what's inspiring my team and me and my work right now. And in the article, I explore aspects of Ruby's care. One aspect is how the patient messages and the asynchronous care has become too much of a good thing. Yeah. I compare primary care physicians' work to Lucy and Ethel and the classic chocolate factory sketch from I Love Lucy, where providers are enjoying having these bonbons of messages coming through on the conveyor belt. We enjoy interacting with our patients in this way, and we want to tend to each and every one of them deliberately and in a dedicated way. However, the flow of the messages, if you think about the metaphorical conveyor belt, has sped up during the COVID pandemic. And it's just become so evident that a team is required to triage and handle the messages so that the primary care physicians don't become overwhelmed. So for Ruby, I have many examples, and for many other patients, it turns out in larger studies, these tech-enabled connections enable us to provide longitudinal care. They've been associated with a reduction in hospitalization rates, with visits to the emergency room, because they've allowed us to provide more proactive and prompt care. We are able to give better access to our patients. But I do want to stress that we need to ensure that technology is working for us in order to sustain the physician workforce and sustain wellness.
Yeah, so take us into the workflow, take us into the office of the ideal primary care practice. You mentioned Ruby, the case study in the article. So take us into that practice and paint us a picture of how that would actually go.
Sure. So, so I would see a Ruby in practice in person or through a video visit. And I would, establish care, understand her medical history. In this case, she was being seen in a different state. She was just coming in to primary care in my panel. And at that time, I enlisted her daughter to help her get on an iPad. And with that iPad, we were able to connect her to a blood pressure cuff. She started to weigh herself every day. And so then she initially was struggling with the technology, but with our team and with her daughter's help, we were able to get her to be one of our most active users. And so she was sending in her blood pressure measurements, she was sending me messages, and I was even able to titrate her hypertension medications all virtually, all through this asynchronous connection. One time we noted, and was actually the cardiology nurse who noted this, that her blood pressure was actually increasing and there were some changes. And we were wondering what was going on because she had been previously very well controlled. And so the cardiology nurse reached out to her, called her. Turns out she was developing a pneumonia. I was able to order a chest x-ray. I was able to talk to her all virtually. This is all during the COVID pandemic. She didn't have COVID. We identified that she had influenza, pneumonia. We were able to treat her as an outpatient. If we had not been able to detect a change in her blood pressure, I don't know if we would have been able to intervene in time to prevent a hospitalization. And so I feel really good about the ways in which we're able to provide, these new ways of providing care. These new modalities are extremely important. And we're just seeing that this is going to lead to a reduction in the cost of care, which we know is a major issue. And this is primary care at its best. Another way that I was able to help her is by having these electronic connections, these e-consultations with specialists. So while the cardiologist never saw her face to face, I was able to receive the cardiologist's expertise and their recommendations. And then I was able to implement them on behalf of the patient. And so through that means, e-consult is also a way that it's providing superpowers to primary care physicians so that we can do what we need to do with our patients and provide them the best care.
Now, not all primary care practice is as well resourced as UCSF. So, what about some of those primary care practices that perhaps have staff shortages that can't fill their staff? Not enough nurses, not enough medical assistants, and they're barely keeping up. So, what kind of ideas can they implement in a practice that don't have as many resources?
Yeah, so I've been very impressed with how far we're able to go in team-based care with our medical assistant. So the partnership between primary care provider and a medical assistant is crucial. Our medical assistants were trained to be health coaches. They were able to respond to a number of those messages that come in for, making appointments, for teeing up prescription refills. There are a number of tasks that a medical assistant can really help with that will then lead to a reduction in the burden on the primary care provider. And we hear time and time again that once the medical assistant is empowered to provide this higher level of care, once they're empowered to practice at the top of what they're able to do, they get more satisfaction and gratification out of their job. But you have to be cautious because I've seen it many times that once the medical assistant is more empowered to do direct primary care, they end up wanting to go into nursing, they end up wanting to go into medical school. And I've seen that time again. And of course, I'm overjoyed and so happy for them. But that is what happens, is they become more proficient in providing healthcare.
So, what's the path forward? How do we get from where we are now to what you describe? Is it purely macro forces that would change and perhaps better finance primary care? Is there anything an individual primary care clinician can do?
Yeah. So I do think that as an individual primary care clinician, the one thing that I want to convey is that a lot of times in the media, and I even mentioned it earlier, that a lot of times in the media, we hear about physician burnout and we think about physician resiliency and we think about self-care. And all of those things are very important. But what I've learned is that physicians are actually incredibly resilient. This is not a resiliency deficit that we're dealing with. And in fact, in many studies, you'll see that physicians on average are more resilient than the general workforce. And so if we think about that not being the problem, we must look at organizations and think about ways in which organizations can be more resilient. So whether it's empowering physicians in leadership positions, looking for more clinician voices in organizations, physicians can also think about developing more quality improvement opportunities in their clinic, getting them engaged, that they're having some control over their work environment to improve their situation. Of course, remuneration is incredibly important, so we don't want to lose sight of that. So advocating for having a salary that is what you would see in the market in the area, and understanding that the role of primary care is slightly different. It's not procedural based. It's not about trying to increase the volume of visits. It's really about preventative care. It's really about trying to see as many people in a population health way so that you're taking care of a population as opposed to the sick care model that we're used to, where we see people when they're sick. So it is a shift in the orientation, but I do believe that because of the rising healthcare costs, we are at a tipping point and we will need to start thinking about investing in primary care so we do get the long-term cost-saving gains that is so critically needed at this time.
So the trend I'm seeing now is that unfortunately more physicians are trending towards specialty and leaving a void, and advanced practice providers like nurse practitioners and physician assistants are filling that primary care void. So in your ideal model, what do you envision the role of nurse practitioners and physician assistants to be?
Yeah, so it's a great question, and it's a very important observation. Absolutely. We're facing a primary care physician workforce shortage. There's no doubt about that. And so how do we collaborate with advanced practice providers so that they are empowered to provide the care? The way that have analyzed many different models and the way that I have seen it work most effectively is when an advanced practice provider is able to contribute as an independent practitioner alongside a physician. And again, in this team-based care model, we're all taking advantage of everyone's expertise in the team. So sometimes a nurse practitioner will have a lengthy experience in podiatry or in oncologic care, and they're in your team. And so we all can learn from each other in that format. And then again, having the primary care physician be there to help an APP with something that's very medically complex, that our medical training is more appropriate in assisting. So that's how I'm sort of seeing it, is that everybody is working together. Maybe we share a panel. Maybe there is some risk stratification of the patients so that more medically complex patients go to a physician. There's a lot of ways that a model can work, and it really depends on the local context and the patient population that a practice is serving.
We're talking to Megan Mahoney. She's a family physician and she's a member of the board of governors at the Doctors Company. We're talking about her KevinMD article, Primary Care 2.0, New Thinking and Practice Design. Megan, what are some of your take-home messages that you want to leave with the KevinMD audience?
Thank you. Primary care serves as the cornerstone of the patient-physician relationship, helping to reduce health disparities, influencing patient engagement, and improving health outcomes. Investing in primary care and the primary care pipeline is essential for expanding access to care and improving quality of care. The time is now to make reforms that secure primary care's central role in the healthcare system.
Well, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you.